Hello, eGP learners. Today, Gandhi and I will be talking about the 25-26 Priorities and Operational Planning Guidance for the NHS. So this is the document that highlights the priorities and focus for ICBs, NHS trusts, other NHS organisations for the coming year. So really important document. And we may also be talking about the neighbourhood working guidance that was discussed briefly last week, and we may talk about that again and see what together we think about it. So let's crack on and tech enhance your primary care and learning.
Hey, GP learners, and welcome to this episode. As Andy said, that we're going to be covering two significant pieces of guidance that came out. Unfortunately, it's not the GP contract, which we still don't have. We didn't think we'd be here, but we are. But in this episode, we're going to cover the NHS Operational Plan, and we're going to recover the NHS Neighbourhood Plan, just to give you that extra little bit of detail and stuff that we've had and things. But how are you doing, Andy? You missed last time, didn't you?
I did, yeah. It's always risky doing a broadcast on a day when I might have to do an evening home visit, and I was just stuck out there in GP land, looking after people. So, but really good to be here today.
Glad that you were, definitely. I'm sure the patients were as well, and very much, your attention was in the right place and stuff. But I know the eGP learners missed you. They had to deal with my microphone woes and stuff last time round. But we have got an amazing episode ready for them in terms of talking about more guidance, haven't we, Andy?
Yeah. Shall we dive in? So I guess first of all, we were going to talk about the guidance for the upcoming year, that laying out the priorities and operational planning guidance. Mm-hmm. So this document, published on, I think, the 30th of January, appeared on the NHS publications website, published by NHS England, and it's really it's a document intended, I think, for ICBs, NHS trusts, large NHS organisations, probably primary care networks. And I think there's stuff of interest in there for practices as well, outlining what the headline priorities for NHS are in the coming year. So I find these documents quite useful as a GP and someone operating at sort of place and primary care network level to know where the priorities are. So if we want to make progress with something locally, these are the ways in which to frame your how you might be bidding for money, or how you might be wanting to influence, up and into the system in terms of wanting to get support for things. Always framing them in terms, or aligning them with the planning guidance is always a really, really good way to do that. And any other ways that you tend to use this document or recommend people might use this document, Gandhi?
No, I think that's the key part, isn't it? Because this is the direction of travel that NHS England has when it comes to the delivery and the actual working place of the NHS in its totality. There is parts of this make reference to general practice, so we will be covering that for you. That's, I think, really important for the eGP learners to understand, but also a broader understanding of the headline things. And some of this will be, absolutely well known and aware of. Some of this may be a little bit new to people out there in terms of some of the stuff that comes up, but shall we get cracking with it?
Yeah, it's good. So I always like looking at the overall structure of a document, when I pick it up. So I think it's helpful when we do that. I hope people find it helpful. So forwards written by Amanda Pritchard, Chief Executive of the NHS. And then we have an introduction that doesn't seem clear who's written it, but obviously the author of the document. Amanda's talking about the achievements of the NHS in recent years, but then also starting to talk about pressure on budget, need for improving access, improving productivity and performance, and the need to make difficult decisions. So that's interesting. Then we've got the introduction, making people dizzy moving through, and then they set out then they set out and summarize the priorities. But at the end of a document, it's often worth skipping to the end, because that's where the annexes are, and often you think, oh, I wish I'd seen that summary table before. So at the end of the document, they summarize all of the main priorities nicely on a single page, which is really, really useful.
So this is probably the main thing that people, if you wanted a quick, what do I need to know? This table is probably the key thing to know, isn't it, Andy?
Yeah, and also the way it's structured is there's the four main priority areas, and then they sort of talk about three other things in terms of how we get there. Where is the focus in terms of how we get there. So let's probably skip back up to the bit just after the introduction, We'll stop making people dizzy with moving around the document in a second, and maybe talk about the main priorities and how we think they might affect general practice. And then there is one priority, which is all about general practice. So maybe
It
have a
is,
dig in
yeah.
there.
Yeah. So the first one is reduce the time people wait for elective care. I mean, this is absolutely no surprise to anyone. We know that the waiting lists are bonkers right now in the post-COVID, and also the challenges that we've had since then in terms of healthcare delivery. So there is no surprise that this is going to be headline, big priority number one, is it, Andy?
Yeah, absolutely. And they talk about moving towards so there's sort of a glide path to by March 2026. Basically, if we get to that actual section, there's a glide path by in a few years in the future. Waiting times will gradually, year on year, reach a more acceptable level in terms of the proportion of patients waiting 18 weeks for treatment after referral. So, and that's that's clearly going to be a big priority. NHS backlogs post-COVID are still a really big problem. Number two is improve A&E waiting times and ambulance response times. Again, I think that's something I see people struggling with, out in the community. I've often called an ambulance and had to wait for it, at a patient's house, for example, and wait times are longer than they used to be. Our ambulance services face a lot of challenges in terms of meeting targets, but improving ambulance response times and A&E wait times are important, and they provide again some figures in terms of where we are aiming with that.
I mean, one of the things I'd probably say, I think, and I'd be interested to know what our eGP learners who are watching us live think about this, but how many times have you had to contemplate or actually transport a patient to a place of safety, such as A&E, because the wait times have been so significant? I know I have once. It's one of those things that you think is a never event because it should never happen, because there are risks and liabilities that you take in terms of taking that risk. But I'd be keen to know what our eGP learners think. And if you're watching this on the replay, then definitely let us know in the comments down below, because I think that'd be really useful for us to know in terms of the impact that people have seen with that. But this is a key thing that we know is going to have an impact. We see headlines recurrently of ambulances waiting outside A&E departments. We've even seen adverts for corridor nursing roles and stuff, because it's that significant of a challenge, isn't it, Andy?
Yeah, yes, it is. And I mean, I think people are doing things, locally to try and improve that transition into A&E from ambulance locally. But often it shifts that wait from in ambulances outside to in the corridor. But people are working really hard to try and address these issues.
Definitely.
But it's a focus going forwards. Number 4. Or was it 3? Improve patients' access to general practice. So I think that's the one that we'll dive down to and have a look at the guidance in detail in that area in a few minutes. And they're talking about improving access to urgent dental care as well. And they want to provide 700,000 additional urgent dental appointments.
Which that doesn't sound like a lot, to be honest, when you think about the population of England.
Yeah, and I don't know what the starting number is in terms of dental appointments as well. But it's a priority, and people do. It is obvious that dental provision is stretched in an area where we're struggling. And then another area is mental health services. So they particularly highlight improve the patient flow through mental health crisis and acute pathways. And then they talk about improving access for children and young people to mental health services as well. And they, give some numbers around the aspirations there. So those are the main, I guess, the main sort of specific targets. And then the other ones are really talking about how we get there in terms of my interpretation. So this is where there's a focus on reform, doing things differently. To drive the reform that will support delivery of our immediate priorities and ensure NHS is fit for the future. We ask ICBs to focus on so reducing demand through developing neighbourhood health service models. So we've seen in previous documents, we've seen a lot of talk about integrated neighbourhood teams, integrated neighbourhood working, and now the language is about sort of neighbourhood health services. So there's a focus on developing those models to support the system. They also are encouraging making full use of digital tools to drive that shift from analog to digital. We just recorded an episode on AI, didn't we, Gandhi?
We did, yeah.
Is potentially one of those tools, but there's lots of other tools that are digital but not AI. And they also about addressing inequalities and a shift towards secondary prevention, which is interesting. And I guess secondary prevention is likely to deliver benefits and improvement for the system before primary or primordial prevention. But it's just interesting there's a specific mention of that type of prevention, not just treatment to prevention, but to secondary prevention.
Can you explain that one a bit more to me, Andy? Because I must admit, I'm slightly confused. So secondary prevention? I've not heard that term before.
No, you have. So you've got 4 types of prevention. So it's primordial prevention, preventing people from
getting sick,
from developing risk factors for being sick at all.
Okay.
So that's about, say, if we take a cardiovascular disease type approach, that's these people have been exercising routinely and eating healthily since children. They never developed those behaviors that might put them at risk in the first place. Primary prevention is about getting people to adopt, say, healthy behaviors that remove them from risk categories for disease, or identifying people who might be at risk. So in terms of cardiovascular disease, people with a poor lipid profile, for example, might have an elevated risk of cardiovascular disease, and we might do certain interventions, lifestyle or giving them drugs, so statins, to reduce that. Secondary prevention is those people who already have a disease, preventing further deterioration or complication. And then tertiary prevention is mitigating the impacts of that disease on people and trying to keep them as healthy as possible. I think I've done that well enough, but I just thought this was interesting because it specifically says it's a secondary prevention rather than all prevention. And I just thought that's interesting.
So thank you for explaining that. You're right, I was aware, but I thought it'd be nice to hear it for everybody else. But I guess the reason why I think it's interesting is it's the first time in a long time I've seen a focus on secondary prevention. It's always been primary prevention for most of the stuff that we've seen, isn't it?
Yeah, well, that's because it's more likely to deliver sort of in-year or near-year cost savings, I think.
True.
And when the system is under pressure and we sort of need immediate results, that's how you're going to get them, I think, in terms of focusing efforts there. But that's interesting because, in primary care networks, we do all sorts of prevention. But actually, if the main interest in the coming year or two is on secondary prevention, then maybe that's where we're going to get more traction with the focus in terms of support within the system. So they also want to live within the budget allocated, reduce waste and improve productivity. I mean, times are tight, right? So I guess, we're going to have to look at these things, but they want us to, balance, have net balanced financial positions for systems. This is important. So that's interesting.
Yeah.
And then I guess whilst doing that, they balance that by saying actually, but also maintain our collective focus on the overall quality and safety of our service. So, and paying particular attention to fragile services, such as maternity. I think the other one is probably
neonatal.
Might say neonatal. And of course, there's a 3-year plan, I think, around those services as well. So, so that's how we get there. And if we think about that table at the end of the document, really, it's giving sort of specific targets around those areas. So yeah, if people have comments or reflections or think having thinking about how these might affect general practice, then
so primary care dermoscopy academy, typical manager speak, trying to justify their jobs and pensions. A little bit strong there. I believe it when I see it. Sounds like Group Commander didn't fare too well in front of the Commons committee, did she? And I think that's more in reference to some of the recent stuff that's happened. But I probably wouldn't put it this strongly. And if they fail to reach targets for improvement, will they be sacked? I wonder if, what is the consequence if the services don't deliver? Well, we've seen that in terms of trusts and that kind of stuff. They often get funding from elsewhere. Interesting, the impact on general practice. If they have a deficit, then the practice closes. So bearing in mind that that's a bit of a different aspect. But I think, we have, as ever, the challenge of trying to remain in budget when the budgets probably aren't able to deliver what they want sometimes. But maybe this will change.
Yeah, and I think ICBs are being told that they need to stay within, a net balanced budget across all of their income expenditure. as well. So it looks like they're quite serious about that. I wonder if primary care demoscopy is being a little playful, because there was some rhetoric from government early in the year, end of last year, talking about making failing NHS managers pay. So, so maybe we're referencing that there.
It's maybe so. We've got a smiley face from Primary Care Demoscopy Academy, and good to hear from Miss Melody, regular of eGPlearning. It's sure good to see you. I'm assuming that's for both of us, Andy, given the fact that we're back on form and back together again. So awesome to do so.
Okay, good.
What's next?
I was going to mention just this. There's just a page on local prioritization and planning, and this is where it talks again about having a financial reset, sort of keeping within budget. And NHS Confed just had some comments, I think, about this particular section, where they said, well, there's a 4% spending uplift in the budget, but given the rates of inflation and healthcare inflation, actually this may feel like a 2% real terms increase for most. So it was to increase in cost pressures for most. So actually a reduction in funding. And they were saying that in order to meet this, there would need to be a 2.2% increase in productivity within the NHS, and in good times the NHS achieves about a 1% productivity increase. So there would need to be quite unprecedented levels of increases in productivity, output per individual worker or per unit spend, in order to make all of this balance and add up. So I just thought that's interesting. It's going to be tough, I guess. And difficult decisions, as Amanda says, will need to be made to meet the objectives within the spending envelope. So what I might do, Gandhi, is just take it off screen, just so I don't make people dizzy while I look for the primary care priority, because that's probably the best place to spend a little bit of time for us, I think.
Page 12.
Page 12. Yes, we'd made a mental note of that before.
We did, yeah.
So I think I am there now.
All right, I'll put it back on. So there we go. So this is page 12 of the operational guidance, as we mentioned, because we kind of wanted to make sure we got to it quickly and effectively for you. And yeah, so do you want to talk us through this, Andy? Because this is the key stuff that many practices will probably want to be aware of, networks and those involved with the ICBs and stuff in particular as well.
So yeah, so essentially they want to continue the deployment rollout of modern general practice. So this is about practices responding to patients, having easy access to GP services and getting a same-day response in terms of what should happen next with your care, which might be an appointment, telephone, face-to-face, might be advice from the practice, might be signposting somewhere else, but making that first on-day contact count for patients. And then they talk about how they might do that. So put in place action plans by June 2025. And I think ICBs need to have some provisional plan in place by the end of March in terms of how they intend to address these elements of guidance, I think. But certainly by June, to improve contract oversight, commissioning and transformation for general practice and tackle unwarranted variations. So a lot of words there, but I think that's probably tighter contract management of general practice on their delivery of modern general practice. That's how I interpret that.
I think this comes to the heart of the recent headlines, which suggested, for example, where Streeting commented about certain practices coasting in general practice. Some people may remember that, with the subsequent retort by GPC chair Katie Bramwell-Stainer. Really excellent reply. I would highly recommend you go off and read that, and we'll see if we can link that to the show notes down below afterwards. But effectively, there's still this concern that there's this unwarranted variation in general practice. And let's be honest, part of that is down to a variety of aspects in terms of the funding mechanisms, in terms of the way that practices are run, which does allow for variation. And actually, that's a good thing sometimes. But also, how can that be managed more effectively? I think what we are seeing from this is the direction that the ICBs will be responsible for a lot of this, rather than NHS England. They're basically handing it off.
Yeah, but they do say that the NHS England will support this by providing national guidance about how this should be done to general practice and commissioners, and evidence-based content and support tools as well. So So that will be helpful, presumably.
Mm-hmm.
So,
Yep.
Yeah. So, I mean, those are the main things. Really.
If I
quickly
can,
moves on
Andy, so the second point on that is to
spiral.
continue to support the delivery of modern general practice and target support to practices based on their ability to provide access and a good overall experience for patients. Now, the reason why I mentioned this is modern general practice, many EGP learners may or may not remember, was the big buzzword from last year in terms of how general practice from NHS England's point of view is being delivered. And there were key aspects in things like the telephony, on signposting, care navigation, all that kind of stuff and things. The key thing is those words have not gone. They are here to stay. And I think that, this is the model that NHS England is keen to push forward in terms of supported contact for patients, and stuff that can be monitored and observed to help inform demand, capacity, and other questions about general practice, and also potentially be monitored a bit more as well.
Yeah, I think so, and that's probably the main thing to look out for in terms of general practice. In addition to, I think, the emphasis on neighbourhood teams, which I think is going to be a big thing for general practice and primary care networks and other primary care providers of the other services that sit with us in primary care, nursing, community services, dentistry, opticians, and all of those as well. It might be worth just going to the summary page, perhaps to wrap up this section, unless there was anything particular that you were wanting to look at elsewhere, Gandhi. It is an interesting document. It is fairly short, actually, as well. So, so I guess just to summarize before we move on, this is a good place to go. So, sort of four priorities and 3. How do we get theirs was what I took away from this, and then the summary page does provide some specifics around the numbers that are targeted. But in the coming year, we're aiming to reduce the wait time, reduce the time people wait for elective care, improve A&E waiting times and ambulance response times, improve access to general practice and urgent dental care, and improve mental health, learning and disabled care, with a particular focus on access to acute mental health services and services for children and young people. And in doing this, living within the allocated budget, achieving productivity improvements, reducing waste, whilst maintaining a focus on quality and safe services, and also addressing inequalities and the shift towards prevention, secondary prevention, it says further up in the guidance. So I guess those are the main focuses. Anything else that struck you about the themes here or the document itself, Gandhi?
So I guess the one I'm going to take off is in the improving access to general practice. Actually, the metric that they're going to use is the ONS Health Insights Survey. Now, is that the GP patient survey, or is it a different one?
No, I think it's different, Gandhi, because the G that they always refer to that as the
GP survey.
GP survey.
Yeah.
So I think that's different, because the ONS don't normally perform.
I've not heard of that.
I think we might have touched on that at some point, but yes, that's interesting. So people need to see what that is for their practice, I guess, and see where the starting point is.
So
just have a look.
I'm
quite sure. I don't think that it's the GP survey.
No,
I noticed that looking through as well. Maybe people out there in eGPlearning land might know as well.
How about we bring this up, Andy? So I'm going to say,
click on the Google.
Yeah, no, I've got it here for you.
So you can share your screen.
Well, no, I was going to put it so you can link it up there.
Put it in the chat.
Done. Yeah. Apologies, EGPlearners. This is completely off the fly, and you can tell this is live because we didn't realize this. But this is what the details of the Health Insight Survey is. I don't think it is. It doesn't look like it's the GP survey at all.
No.
It's a different one. So it's based off the census data, which confused me slightly. Yeah. So it looks like this is a new survey, but the reason why I wanted to raise this is that when we looked at that table just now, this is how they're going to measure impact of general practice access. So the feedback of that will be based on this particular survey. So yeah, it's a bit different. So So this will be a current one. The Health Insight Survey questionnaire will be used to collect data from the 15th of October 2024 onwards, is what it says in the document. It's completely optional. It keeps your data confidential, and leaving the survey, I think it's a prospective survey. It continues on. But yeah, I think we may have found a future episode here, Andy.
Yep, we'll have a look at that and have a look at the data when it starts coming through. So,
Okay.
Yeah, I guess the key things for the operational planning, for me, I guess, is just focus on delivering within financial constraints, and productivity increases, probably heralding the need to do things differently and think about the impact of services. So potentially some difficult decisions about or recommissioning of services, and an emphasis on sort of neighborhood health services that emerges as a concept, but still doesn't feel too crystallized to me, which might be a segue into the neighborhood guidance that
Yes.
So you spoke about this last time, so I don't think people need another blow by blow walk through the document. But I was keen to still have a conversation with you about it, Gandhi, because I felt I'd missed out.
Well, let's go
time.
for it. So let's just zoom in a little bit on that. And then I guess just to give a very brief recaps for those. So the neighborhood plan, or the neighborhood health guidelines, as it's called for 25-26, is basically a direction or document that very much sets the tone, I felt, for this kind of plan that they have of various documents all weaving together to form what will likely be the culmination of the 10-year plan for the NHS and stuff, which we're still waiting to have. And that the two remaining parts that we haven't got from these guidances that it talks about is the 10-year plan and obviously the GP contract. I know you like this diagram that showcased a lot of stuff, and then this feeds into the 6 core priorities, which we'll get to in a second. But do you want to talk us through this particular part, Andy?
Yeah, I mean, what I took away from this structure was, like, there's a diagram, there's 3 shifts, and there's 6 priorities. So
Yeah.
1, 3, 6. So over the next 5 to 10 years, so interesting timescales, not immediately. We want the NHS and social care working together to prevent people spending unnecessary time in hospital or care homes, by strengthening primary and community-based care to enable more people to be supported closer to home or work. So that's within the neighborhood, and connecting people accessing health and care to wider public services and third sector support, including social care, public health, and other local government services. And they also talk about the community and voluntary sector quite a lot within the document as well. And those 3 shifts, we're familiar with them from the Darzi report. So hospital to community, treatment to prevention, and analog to digital. So
yeah,
they talk about that within the document. And then there are just trying to think where it's where the 6 are summarized.
It's lower down. So they don't
document.
actually summarize them, but to outline that. So it's actually in the annex.
A, B, C, D. Yeah.
Yeah, it's all the way down in the annex. So these 6 key core aspects are population health management, modern general practice, which we talked about earlier as part of the operational plan. See how it's still there? Yep. This is the key thing that's coming through. I suspect this is where well, I highly suspect this is where the GP contract will focus on. It will focus on modern general practice for general practice,
because they do develop themes through these through these documents. You can sort of see what's coming next by seeing what's increasing in popularity. So yeah, modern general practice, that'll be neighborhood health.
Standardizing community services, the neighborhood MDT, which I know I spent a lot of time talking about, intermediate care with a home first approach, and then finally urgent community response. Those are the 6 core aspects of the neighborhood guidelines and things. What did you think of them, Andy?
Yeah, so I just thought about I thought about each one in turn when I was having read through the document, thinking about how is this going to apply to my role as a GP, really, or at place or in primary care network. So population health management. So I thought about, actually this is about cohort focusing, I think, or it's about the use of data, isn't it? To and they talk actually in the document, I think, about linked data sets. So linking, health data more with social data to gain insights about people and how we can help people and communities with their health. So I thought, actually, this is going to, cohorting of patients and focusing on delivering care for cohorts and community is probably going to be important. going forwards. Modern general practice is modern general practice. So interesting, there's the focus there. And I think there's no getting away from moving toward, well, or from continuing to deliver modern general practice. It's a contractual requirement. And we saw that in the operational guidance as well. Standardizing community care services. Less sure what to make about that. Obviously, there'll be there's always an aspiration to reduce variation in services, isn't there? And I think that's sort of where they're driving with that. We talk about standardizing, but there's all, but also we want to personalize, don't we, as well? So there's a potential tension there. I thought the neighborhood multidisciplinary teams was something that really piqued my attention, which sounds a lot like integrated neighborhood working and integrated neighborhood teams. And I think we may be using these terms interchangeably now. They talked particularly about the voluntary and what do they call it? The voluntary
care sector, yeah.
Voluntary care sector, yeah. So I think there's a letter I'm missing out.
VCFS, I think it was.
VCFS, yes. Voluntary something. Anyway, so making sure that they are included where appropriate, I think is really interesting, but definitely a focus on delivering care through linked services. They talked about those multidisciplinary teams being planned and proactive, as well as responsive. So for kind of both of those types of care, in terms of responsive care when something happens, but also getting ahead of problems in terms of being planned and proactive. They talked about cohorts, and I think potentially focusing on complicated cohorts initially. I think frailty is often a popular target. So I think if people are thinking about where to focus their development of integrated neighborhood working, integrated neighborhood teams, that's beginning to feel like
I think in particular they talked about how 7% of the population accounts for approximately 46% of the cost in hospital care. So clearly the compound gains you would have by supporting that 7% to reduce their use or needs or ways that things are done would have a compound impact in terms of that savings and potential benefits to the patients.
Yeah, that makes a lot of sense. And I think that's where focusing on understanding who those are, I guess, using your health data, and then focusing on those cohorts, and often it's frailty or people who are facing complex and multiple challenge in terms of their health or circumstances are popular places to go. And they talk about the use of care coordination and care coordinators, and that's something that the things I've seen over the years that anecdotally seems to deliver in terms of keeping people out of hospital. I think about the community matron service locally, who provide skilled case management of particularly frail or vulnerable people. And anecdotally, I see evidence of that keeping my patients out of hospital. So I think care coordination is useful and important. And they also talk about single point of access approaches as well. And things can be so confusing for patients, can't they? There's so many different places people can get care from. Actually, focusing on single points of access for neighbourhood care, starts to feel useful. And I do wonder if that's the GP through modern general practice potentially. So I thought that was interesting. I thought the urgent neighbourhood services was interesting to me as well, and I wondered if that might look like kind of acute care streams for general practice potentially, and that might be what they are driving.
So I think the urgent community responses around those services to try and prevent people from getting into hospital. So slightly different to step up and step down, but in terms of additional services, so particularly the walk-in centres, you may have similar kind of mechanisms for housebound patients, frail patients, etc. in your area, those kind of things.
Talk about virtual wards in that section. So I think they talk about single points of access again for urgent services, virtual wards, and then like the urgent treatment locations. So so those were just some of the concepts that I'd sort of picked out of it that I thought were really interesting. The other things that came up were they talk about secondary care's contribution, and that is expected to be significant. I think, in terms of making this all work. So I think that's useful. And it is difficult to see how a shift of care from secondary care to primary care can work without some transfer of resources. So I thought it was good that that is acknowledged. So that was good to see. And then there's a section on workforce as well, talking about planning for the workforce required for neighbourhood working, and the need for a flexible workforce. And I think that's one of the big challenges to make this work, really, both because I think we're talking about working differently. I think we are talking about doing some additional work here as well, and it's difficult where that's not funded and you have to release people from doing other things that are perhaps deemed lower value by the system, liberating cough indicators, or other work. But it's difficult to know what that low value work is, because there's generally quite good value to everything that we do. And just got me thinking about how you actually get people working across organizational boundaries, because I guess, I'm sure you feel the same, but where we've been involved in early sort of movements towards this way of working, people are often working within their community care organization, their general practice, their primary care network, the hospital, and actually those organizations have quite tight requirements on their performance, and it's difficult for them to then release staff, release time, release resources to support neighborhood working as it is at the moment. So something I think needs to be done to facilitate the release of resources to support neighbourhood working. So I guess those were my thoughts. For what it's worth, Gandhi, I think it's going to be a really big theme in upcoming documents and over the coming years. So watch the space.
And I guess hearing from the eGPlearner, so Shankar Vijay Adeva, good friend of mine actually, knows his System 1 very well. So, people always look to me for System 1 knowledge. Shankar knows his stuff as well. Let me be clear on this point. He's got some awesome videos as well. But yeah, I love the comment that, we need a single point of access for all the single points of access. And if you've worked in general practice, you will absolutely understand what that means.
I do. It often means it's us in general practice.
Well, that's the thing.
So we're perceived as the most accessible.
Yes.
And just in case you want to bring that up. So Shankar's passed the baton back to you. No, you're the king of System 1, Gandhi. He's passed the baton back to you. The crown.
No, he's doing some amazing work down in Northwest London and stuff. So definitely, they're looked after well there. So we've covered two pretty significant pieces of documentation that have come out. Normally would have done on NHS Publications Container Corner thing, which we still have to come up with a jingle for, Andy. In fact, I'm going to task you with the job to do that.
I'll find some music.
Yeah. But the reason we haven't covered that today is because actually there hasn't been any major documentation that's come out in that particular area recently. We avidly still await the GP contract, and I think me and Andy are committed to try and cover that fairly soon after it comes out. If it comes out, when it comes out, who knows at this rate. It seems to be
just a case of when.
It's just, it's got to be a case of when. At the very least, it'll be the 31st of March. Maybe me and Andy will be there on that date, ready to go, covering it all for you and stuff. I guess worth covering some of the other stuff that we're up to in the next few weeks. So PCN Plus 25, if you haven't signed up and you're planning on coming, I would highly recommend you do that pretty soon, because we're about 80% full now, aren't we, Andy? And we've still got 6 weeks to go. Possibly
lots of interest, and hopefully we will have the contract released by then, so that we can all get together and have a really good chat.
Given it's in April, the conference is in April, it should be the contract is out, and absolutely
we'll be operating under it. So
exactly. If you haven't signed up for GP 529, that's similar time, a few days afterwards. In fact, me and Andy doing our regular 6 monthly GP trainers kind of residential online support you all and stuff. I guess some updates for eGPlearners in terms of some of the other content that I know you all love. So in the next few weeks, you're going to see quite a few pieces of videos coming out from myself, particularly focusing on AI in general practice. Some of that's sponsored, some of it's not, some of it's some of my own hints and tips. as well as quite a few cool providers coming on. So Hero Health making their debut on the eGPlearning, as well as Accurix. So I've got a specific live stream with Accurix on the 12th of March. You will not want to miss. It's going to be awesome. And some awesome content as well coming out from other providers like Anima and various other people. And a really interesting one that I think is going to make practice managers very happy coming soon as well. So don't worry, practice managers. I haven't forgotten you. You're in my thoughts, and I'm going to try and do something to help you. And you will want to check this out and stuff. But sneak peek, not yet, I'm afraid. What about you, Andy? I know you got loads on as well.
Yeah, that on. So we're continuing to work on integrated neighbourhood working at Nottingham City Place, which is really, really interesting. Carrying on with interesting work at the interface of primary and secondary care. That's a really interesting space as well. I've been doing some mini podcasts looking at things happening within the local system, which I might start talking a little bit more about here. So that's just conversations with things happening in the health and social care space in Nottingham. So. Talking to people about how we support people experiencing homelessness, gambling, all of these things at the intersection of health and social care. So I might start talking a little bit more about that in the future, and pop some links down below if people are interested.
Okay, so just before we sign off, everyone, we're going to give you a quick summary of what we've covered so far today. Are you ready for this, Andy?
I'm ready. I'm ready, actually. I was thinking, I hope you hand off to me for this. So thanks everyone for attending. We've had a really exciting episode. We have covered 2 documents today. So we've covered the national, we have covered the operational planning guidance for 25-26. Essentially, there are 4 priorities and 3 ways of doing it that we talked about. We talked about the priorities to reduce the time people wait for elective care, the priority to improve A&E waiting times and ambulance response times, 2, improve patients' access to general practice, including the ongoing delivery of modern general practice, and improve people's access to urgent dental care as well, and also to improve patient flow through mental health services, particularly acute services and crisis teams, and improve access of children and young people to mental health services. And in doing this, ICBs and large NHS organisations should be driving the reform that will support delivery of our immediate priorities and ensure the NHS is fit for service in the future. So looking at developing neighbourhood health service models, making full use of digital tools, and continue to address health inequalities, whilst also living within our allocated budgets and reducing waste and improving productivity, and maintaining the focus on quality and safety. Those are the main upshots in that document. We then also talked about the integrated neighbourhood guidance, and that can be summarised in a diagram, 3 shifts and 6 priorities. The diagram is NHS social care working together to prevent people spending unnecessary time in hospitals or care homes, strengthening primary and community-based care to enable more people to be supported closer to home or work, and connecting people accessing health and care to wider public services and third sector support, including social care, public health, and other local government services and the voluntary sector. That's the diagram of neighbourhood health, and doing this through 3 shifts, hospital to community, we could say them together, treatment to prevention, and analog to digital, with 6 priorities, which are population health management, continuing to apply modern general practice, standardizing community health services, neighbourhood multidisciplinary teams, integrated intermediate care with a home first approach, and urgent neighbourhood services with a particular mention of virtual wards, single point of access, and urgent treatment centres. That's what we know so far about neighbourhood working. Hopefully I did that in a reasonable time frame.
You did an amazing job there, Andy. I mean, we're going to try and commit ourselves to giving you these summaries every big episode that we do. I have no idea how we're going to summarize the GP contract when it comes out, but we will see. We have yet to see it. But absolutely, if you want to check that out, then do let us know. That summary will be released as a separate mini episode. So if for some reason you can't join us for these bigger, long, in-depth dives and stuff, do check out the summaries, which we republish a few days later. And speaking of coming content, so we talked about GP5T9, we talked about the PCN Plus, we talked about all the live streams and stuff. Next week, if you want to join us, we will be talking about the AI playbook given by the government and how this will particularly impact you and your practice and general practice and stuff. So if you want to check out that episode, make sure you subscribe. Alternately, if you haven't done so already and found this content really useful, do leave us a like down below. Lets us know, and it lets the algorithms know that we're doing a reasonably good job of hopefully informing you about technically enhancing primary care and learning. And we will catch you on the next episode. Bye.